All right, now we're going to work on Module 4, going over mobility. A lot of reading. It's literally only reading, no PowerPoint. Sucks. It's okay. This one is a long boy, but I think it's the longest one. So we'll go ahead and jump right into it right now, all right? Let's do it.
Scientific knowledge base. Nature of movement. Movement is a complex process that requires coordination between the musculoskeletal and nervous systems. As a nurse, you will consider how a patient's physical and psychological condition affect body movement. Body mechanics is a term that describes the coordinated efforts of the musculoskeletal and nervous systems. Knowing how patients initiate movement and understanding your own movements requires a basic understanding of the physics surrounding body mechanics. The body mechanics applied in the lifting techniques historically used in nursing practice often cause debilitating injuries to nurses and other healthcare staff. Burnfield et al., 2013, Griffiths, 2012. Today, nurses use evidence-based information about body alignment, balance, gravity, and friction when implementing nursing interventions such as positioning patients, determining the risk of patient falls, and selecting the safest way to move or transfer patients. Healy and Darowski, 2012. Alignment and balance. The terms body alignment and posture are similar and refer to the positioning of the joints, tendons, 408 ligaments, and muscles while standing, sitting, and lying. Body alignment means that an individual's center of gravity is stable. Correct body alignment reduces strain on musculoskeletal structures, aids in maintaining adequate muscle tone, promotes comfort, and contributes to balance and conservation of energy. Without balance control, the center of gravity is displaced. Individuals require balance for maintaining a static position, example sitting, and moving, example walking. Disease, injury, pain, physical development, example age and life changes, example pregnancy, compromise the ability to remain balanced. Medications that cause dizziness and prolonged immobility affect balance. Impaired balance is a major threat to mobility and physical safety and contributes to a fear of falling and self-imposed activity restrictions. McMahon and Fleury, 2012, see Chapter 39. Gravity and friction. Weight is the force exerted on a body by gravity. The force of weight is always directed downward, which is why an unbalanced object falls. Unsteady patients fall if their center of gravity becomes unbalanced because of the gravitational pull on their weight. To lift safely, the lifter has to overcome the weight of the object and know its center of gravity. In symmetrical inanimate objects, the center of gravity is at the exact center of the object. However, people are not geometrically perfect. Their centers of gravity are usually at 55% to 57% of standing height and are in the midline, which is why only using principles of body mechanics in lifting patients often leads to injury of a nurse or other healthcare professional. See Chapter 39. Friction is a force that occurs in a direction to oppose movement. The greater the surface area of the object that is moved, the greater is the friction. A larger object produces greater resistance to movement. In addition, the force exerted against the skin while the skin remains stationary and the bony structures move is called shear. Unfortunately, a common example is when the head of a hospital bed is elevated beyond 60 degrees and gravity pulls a patient so that the bony skeleton moves toward the foot of the bed while the skin remains against the sheets. The blood vessels in the underlying tissue are stretched and damaged, resulting in impeded blood flow to the deep tissues. Ultimately, pressure ulcers often develop within the undermined tissue. The surface tissue appears less affected. See Chapter 48. To decrease surface area and reduce friction when patients are unable to assist with moving up in bed, nurses use an ergonomic assistive device such as a full body sling. This sling mechanically lifts a patient off the surface of a bed, thereby preventing friction, tearing, or shearing his or her delicate skin, and protects the nurse and other staff from injury. Burnfield et al., 2013. Skeletal System. The skeletal system provides attachments for muscles and ligaments and the leverage necessary for mobility. Thus, the skeleton is the supporting framework of the body and is made up of 4 types of bones: long, short, flat, and irregular. Bones are important for mobilization because they are firm, rigid, and elastic. The aging process changes the components of bone, which impacts mobility. Firmness results from inorganic salts such as calcium. You need to know 410 how to apply these scientific principles in the clinical setting to determine the safest way to move patients and to understand the effect of immobility on the physiological, psychosocial, and developmental aspects of patient care. Factors influencing mobility. To determine how to move patients safely, you will assess their ability to move. Mobility refers to a person's ability to move about freely, and immobility refers to the inability to do so. Think of mobility as a continuum, with mobility on one end, immobility on the other, and varying degrees of partial immobility between the endpoints. Some patients move back and forth between mobility and immobility, but for others immobility is absolute and continues indefinitely. The terms bed rest and impaired physical mobility are used frequently when discussing patients on the mobility-immobility continuum. Bed rest is an intervention that restricts patients to bed for therapeutic reasons. Although it is much less commonly used, healthcare providers most often prescribe this intervention. Bed rest has many different interpretations among healthcare professionals. The duration of bed rest depends on the illness or injury and a patient's prior state of health. The effects of muscular deconditioning associated with lack of physical activity are often apparent in a matter of days. This cluster of symptoms is often referred to as the hazards of immobility. The individual of average weight and height without a chronic illness on bed rest loses muscle strength from baseline levels at a rate of 3% a day. Immobility also is associated with cardiovascular, skeletal, and other organ changes. The term disuse atrophy describes the tendency of cells and tissue to reduce in size and function in response to prolonged inactivity resulting from bed rest, trauma, casting of a body part, or local nerve damage. McCants and Huther, 2014. Periods of immobility due to disability or injury or prolonged bed rest during hospitalization cause major physiological, psychological, and social effects. These effects are gradual or immediate and vary from patient to patient. The greater the extent and the longer the duration of immobility, the more pronounced the consequences. The patient with complete mobility restrictions is continually at risk for the hazards of immobility. When possible, it is imperative that patients, especially older adults, have limited bed rest and that their activity is more than bed to chair. Loss of walking independence increases hospital stays, need for rehabilitation services, or nursing home placement. In addition, the deconditioning related to reduced walking increases the risk for patient falls. AAN, 2015, Pashakanti and Von Ott, 2012. Systemic effects. All body systems work more efficiently with some form of movement. Exercise has positive outcomes for all major systems of the body. When there is an alteration in mobility, each body system is at risk for impairment. The severity of the impairment depends on a patient's overall health, degree, and length of immobility, and age. For example, older adults with chronic illnesses develop pronounced effects of immobility more quickly than do younger patients with the same immobility problem. Metabolic changes. Changes in mobility alter endocrine metabolism, calcium resorption, and functioning of the gastrointestinal system. The endocrine system, composed of hormone-secreting glands, maintains and regulates vital functions such as 1. Response to stress and injury, 2. Growth and development, 3. Reproduction, 4. Maintenance of the internal environment, and 5. Energy production, use, and storage. When injury or stress occurs, the endocrine system triggers a series of responses aimed at maintaining blood pressure and preserving life. It is important in maintaining homeostasis. Tissues and cells live in an internal environment that the endocrine system helps regulate through maintenance of sodium, potassium, water, and acid-base balance. It also regulates energy metabolism. Thyroid hormone increases the basal metabolic rate, BMR, and energy becomes available to cells through the integrated action of gastrointestinal and pancreatic hormones, McCants and Huther, 2014. Immobility disrupts normal metabolic functioning, decreasing the metabolic rate, altering the metabolism of carbohydrates, fats, and proteins, causing fluid, electrolyte, and calcium imbalances, and causing gastrointestinal disturbances such as decreased appetite and slowing of peristalsis. However, in the presence of an infectious process, immobilized patients often have an increased BMR as a result of fever or wound healing because these increase cellular oxygen requirements, McCants and Huther, 2014. A deficiency in calories and protein is characteristic of patients with a decreased appetite secondary to immobility. The body is constantly synthesizing proteins and breaking them down into amino acids to form other proteins, see Chapter 45. When the patient is immobile, his or her body often excretes more nitrogen, the end product of amino acid breakdown, than it ingests in proteins, resulting in negative nitrogen balance. Weight loss, decreased muscle mass, and weakness result from tissue catabolism, tissue breakdown, McCants and Huther, 2014. Another metabolic change associated with immobility is calcium resorption, loss, from bones. Immobility causes the release of calcium into the circulation. Normally the kidneys excrete the excess calcium. However, if they are unable to respond appropriately, hypercalcemia results. Pathological fractures occur if calcium resorption continues as a patient remains on bed rest or continues to be immobile, McCants and Huther, 2014. Impairments of gastrointestinal functioning caused by decreased mobility vary. Difficulty in passing stools, constipation, is a common symptom, although pseudodiarrhea often results from a fecal impaction, accumulation of hardened feces. Be aware that this finding is not normal diarrhea, but rather liquid stool passing around the area of impaction, see Chapter 47. Left untreated, fecal impaction results in a mechanical bowel obstruction that partially or completely occludes the intestinal lumen, blocking normal propulsion of liquid and gas. The resulting fluid in the intestine produces distension and increases intraluminal pressure. Over time intestinal function becomes depressed, dehydration occurs, absorption ceases, and fluid and electrolyte disturbances worsen. Respiratory changes. Regular aerobic exercise enhances respiratory functioning. In contrast, lack of movement and exercise places patients at risk for respiratory complications. Patients who are immobile are at high risk for developing pulmonary complications such as atelectasis, collapse of alveoli, and hypostatic pneumonia, inflammation of the lung from stasis or pooling of secretions. Both decreased oxygenation and prolonged recovery add to patients' discomfort, Lewis et al., 2013. In atelectasis secretions block a bronchiole or a bronchus, and the distal lung tissue, alveoli, collapses as the existing air is absorbed, producing hypoventilation. The site of the blockage affects the severity of atelectasis. Sometimes an entire lung lobe or a whole lung collapses. At some point in the development of these complications, there is a proportional decline in the patient's ability to cough productively. Ultimately the distribution of mucus in the bronchi increases, particularly when the patient is in the supine, prone, or lateral position. Mucus accumulates in the dependent regions of the airways, figure 28:1. Hypostatic pneumonia frequently results because mucus is an excellent place for bacteria to grow. Figure 28:1 pooling of secretions in dependent regions of lungs in supine position. Cardiovascular changes. Immobilization also affects the cardiovascular system, frequently resulting in orthostatic hypotension, 411 increased cardiac workload, and thrombus formation. Orthostatic hypotension is a drop of blood pressure greater than 20 mm Hg in systolic pressure or 10 mm Hg in diastolic pressure and symptoms of dizziness, lightheadedness, nausea, tachycardia, pallor, or fainting when the patient changes from the supine to standing position, Ball et al., 2015. In the immobilized patient decreased circulating fluid volume, pooling of blood in the lower extremities, and decreased autonomic response occur. These are especially evident in the older adult. As the workload of the heart increases, so does its oxygen consumption. Therefore the heart works harder and less efficiently during periods of prolonged rest. As immobilization increases, cardiac output falls, further decreasing cardiac efficiency and increasing workload. Patients who are immobile are also at risk for thrombus formation. A thrombus is an accumulation of platelets, fibrin, clotting factors, and the cellular elements of the blood attached to the interior wall of a vein or artery, which sometimes occludes the lumen of the vessel, figure 28-2. 3 factors contribute to venous thrombus formation. 1. Damage to the vessel wall, example injury during surgical procedures. 2. Alterations of blood flow, example slow blood flow in calf veins associated with bed rest. And 3. Alterations in blood constituents, example a change in clotting factors or increased platelet activity. These 3 factors are often referred to as Virchow's triad, McCants and Huether, 2014. As a nurse you will practice in numerous situations when deep vein thrombosis, DVT, must be prevented, especially during perioperative care, see Chapter 50. Figure 28-2 Thrombus formation in a vessel. Musculoskeletal changes. Immobility affects the musculoskeletal system by causing permanent or temporary impairment or permanent disability. Restricted mobility sometimes results in loss of endurance, strength, and muscle mass and decreased stability and balance. Other effects of restricted mobility affecting the skeletal system are impaired calcium metabolism and joint mobility. Muscle effects. Because of protein breakdown, a patient loses lean body mass during immobility. The reduced muscle mass makes it difficult for patients to sustain activity without increased fatigue. If immobility continues and the patient does not exercise, there is further loss of muscle mass. Prolonged immobility often leads to disuse atrophy. Loss of endurance, decreased muscle mass and strength, and joint instability, see skeletal effects, place patients at risk for falls, see Chapter 39. Skeletal effects. Immobilization causes 2 skeletal changes, impaired calcium metabolism and joint abnormalities. Because immobilization results in bone resorption, the bone tissue is less dense or atrophied, and disuse osteoporosis results. When disuse osteoporosis occurs, a patient is at risk for pathological fractures. Osteoporosis is a major health concern in this country. It is predicted that by 2025 it will be responsible for approximately 3 million fractures and $25.3 billion in costs each year. Furthermore, the National Osteoporosis Foundation, 2014, reports that about 54 million Americans have osteoporosis and low bone mass. Studies suggest that approximately 1 in 2 women and up to 1 in 4 men age 50 and older will break a bone as a result of osteoporosis. Although primary osteoporosis is different in origin from the osteoporosis that results from immobility, it is imperative that nurses recognize that immobilized patients are at high risk for accelerated bone loss if they have primary osteoporosis. Immobility can lead to joint contractures. A joint contracture is an abnormal and possibly permanent condition characterized by fixation of a joint. It is important to note that flexor muscles for joints are stronger than extensor muscles and therefore contribute to the formation of contractures. Disuse, atrophy, and shortening of the muscle fibers cause joint contractures. When a contracture occurs, the joint cannot achieve full ROM. Contractures sometimes leave a joint or joints in a non-functional position, as seen in patients who are permanently curled in a fetal position. Early prevention of contractures is essential, but one common and debilitating contracture is foot drop, figure 28-3. When foot drop occurs, the foot is permanently fixed in plantar flexion. Ambulation is difficult with the foot in this position because the patient cannot dorsiflex the foot. A patient with foot drop is unable to lift the toes off the ground. Patients who have suffered CVAs with resulting right or left-sided paralysis, hemiplegia, are at risk for foot drop. Figure 28-3 foot drop. Urinary Elimination changes. Immobility alters a patient's urinary elimination. In the upright position, urine flows out of the renal pelvis and into the ureters and bladder because of gravitational forces. When a patient is recumbent or flat, the kidneys and ureters move toward a more level plane. Urine formed by the kidney needs to enter the bladder unaided by gravity. Because the peristaltic contractions of the ureters are insufficient to overcome gravity, the renal pelvis fills before urine enters the ureters, figure 28-4. This condition is called urinary stasis and increases the risk of urinary tract infection and renal calculi 412, see Chapter 46. Renal calculi are calcium stones that lodge in the renal pelvis or pass through the ureters. Immobilized patients are at risk for calculi because they frequently have hypercalcemia. Figure 28-4 Stasis of urine with reflux to ureters. As the period of immobility continues, fluid intake often diminishes. When combined with other problems such as fever, the risk for dehydration increases. As a result, urinary output declines on or about the 5th or 6th day after immobilization, and the urine becomes concentrated. This concentrated urine increases the risk for calculi formation and infection. Another cause of urinary tract infections in immobilized patients is the use of an indwelling urinary catheter. Integumentary changes. The changes in metabolism that accompany immobility add to the harmful effect of pressure on the skin in immobilized patients. This makes immobility a major risk factor for pressure ulcers. Any break in the integrity of the skin is difficult to heal. Preventing a pressure ulcer is much less expensive than treating one, therefore preventive nursing interventions are imperative. WOCN, 2010. A pressure ulcer is an impairment of the skin as a result of prolonged ischemia, decreased blood supply, in tissues, see Chapter 48. An ulcer is characterized initially by inflammation and usually forms over a bony prominence. Ischemia develops when the pressure on the skin is greater than the pressure inside the small peripheral blood vessel supplying blood to the skin. Tissue metabolism depends on the supply of oxygen and nutrients to and the elimination of metabolic wastes from the blood. Pressure affects cellular metabolism by decreasing or totally eliminating tissue circulation. When a patient lies in bed or sits in a chair, the weight of the body is on bony prominences. The longer the pressure is applied, the longer is the period of ischemia and therefore the greater the risk of skin breakdown. The prevalence of pressure ulcers is highest in long-term care facilities, whereas hospital-acquired pressure ulcers are the highest in adult intensive care units. Peterson et al., 2013. Psychosocial effects. Immobilization often leads to emotional and behavioral responses, sensory alterations, and changes in coping. Illnesses that result in limited or impaired mobility can cause social isolation and loneliness. Parker, 2012. Every patient responds to immobility differently. 413. Patients with restricted mobility may have some depression. Depression is an affective disorder characterized by exaggerated feelings of sadness, melancholy, dejection, worthlessness, emptiness, and hopelessness out of proportion to reality. It results from worrying about present and future levels of health, finances, and family needs. Because immobilization removes a patient from a daily routine, he or she has more time to worry about disability. Worrying quickly increases a patient's depression, causing withdrawal. Withdrawn patients often do not want to participate in their own care. Developmental changes. Immobility often leads to developmental changes in the very young and in older adults. The immobilized young or middle-aged adult who has been healthy experiences few, if any, developmental changes. However, there are exceptions. For example, a mother with complications following birth has to go on bed rest and as a result cannot interact with her newborn as expected. Infants, toddlers, and preschoolers. The newborn infant's spine is flexed and lacks the anteroposterior curves of the adult. See Chapter 12. As the baby grows, musculoskeletal development permits support of weight for standing and walking. Posture is awkward because the head and upper trunk are carried forward. Because body weight is not distributed evenly along a line of gravity, posture is off balance, and falls occur often. When an infant, toddler, or preschooler becomes immobilized, it is usually because of trauma or the need to correct a congenital skeletal abnormality. Prolonged immobilization delays a child's gross motor skills, intellectual development, and musculoskeletal development. Adolescence. The adolescent stage usually begins with a tremendous increase in growth. See Chapter 12. When the activity level is reduced because of trauma, illness, or surgery, the adolescent is often behind peers in gaining independence and accomplishing certain skills such as obtaining a driver's license. Social isolation is a concern for this age group when immobilization occurs. Adults. An adult who has correct posture and body alignment feels good, looks good, and generally appears self-confident. The healthy adult also has the necessary musculoskeletal development and coordination to carry out ADLS. See Chapter 13. When periods of prolonged immobility occur, all physiological systems are at risk. In addition, the role of the adult often changes with regard to the family or social structure. Some adults lose their jobs, which affects their self-concept. See Chapter 34. Older adults. A progressive loss of total bone mass occurs with older adults. Some of the possible causes of this loss include decreased physical activity, hormonal changes, and bone resorption. The effect of bone loss is weaker bones. Older adults often walk more slowly, take smaller steps, and appear less coordinated. Prescribed medications alter their sense of balance or affect their blood pressure when they change position too quickly, increasing their risk for falls and injuries. See Chapter 14. The outcomes of a fall include not only possible injury but also hospitalization, loss of independence, psychological effects, and quite possibly death. McMahon and Fleury, 2012. Older adults often experience functional status changes secondary to hospitalization and altered mobility status. Box 28-2. Immobilization of older adults increases their physical dependence on others and accelerates functional losses. Padula et al., 2009. Immobilization of some older adults results from a degenerative disease, neurological trauma, or chronic illness. In some it occurs gradually and progressively, in others, especially those who have had a stroke, it is sudden. When providing nursing care for an older adult, encourage the patient to perform as many self-care activities as possible, thereby maintaining the highest level of mobility. Sometimes nurses inadvertently contribute to a patient's immobility by providing unnecessary help with activities such as bathing and transferring. Box 28-2. Focus on older adults. Functional decline in hospitalized immobile older adults. For many older adults, admission to a hospital often results in functional decline despite the treatment for which they were admitted. Some older adults have problems related to mobility and quickly regress to a dependent state. Usual aging is associated with decreased muscle strength and aerobic capacity, which become exacerbated if a patient's nutritional state is poor. A nutritional assessment needs to be included in the plan of care for the older adult experiencing immobility. Anorexia and insufficient assistance with eating lead to malnutrition, which contributes to the known problems associated with immobility. Improved nutrition increases patients' ability to perform physical reconditioning exercises. Padula et al., 2009. There is a direct relationship between the success of older adults' rehabilitation and their nutritional status. Nursing process. Apply the nursing process and use a critical thinking approach in your care of patients. The nursing process provides a clinical decision-making approach for you to develop and implement an individualized plan of care. Patients with pre-existing mobility impairments and those who are at risk for immobility will greatly benefit from a care plan that improves the patient's functional status, promotes self-care, maintains psychological well-being, and reduces the hazards of immobility. Assessment. Your assessment of a patient must consider his or her normal mobility status, the effects of any diseases or conditions on mobility, and the patient's risks for mobility alterations as a result of treatments. Critically analyze findings to ensure that you make patient-centered clinical decisions required for safe nursing care. Through the patient's eyes. Usually you will assess a patient's degree of mobility and immobility during the history interview and physical examination, box 28-3. Keep in mind that the patient is a full partner in providing information and designing the plan of care. It is important to understand how any limitations in mobility are perceived by the patient. Has the patient had a disability for an extended period of time, and is he or she well adapted to the use of an assist device or even a wheelchair? Is the limitation in mobility sudden and unexpected, causing the patient to be fearful or full of questions? Always convey respect for the patient's preferences, values, and needs during assessment and when designing a plan of care. Ackley and Ladwig, 2014. Box 28-3. Nursing assessment questions. Mobility. Describe any changes you've noticed in your ability to walk and take care of yourself on a daily basis. Have you experienced any stiffness, swelling of a joint, muscle or joint pain, or difficulty with moving? If so, describe how you are affected. Have you noticed any shortness of breath? If so, does it worsen when walking? Immobility. Describe your normal daily activity. Has this changed recently? How have your appetite and diet changed since you've had problems moving around? Describe what you eat in a normal day. Does your day seem very long? Are you sleeping well at night? Have you noticed any places on your skin that are reddened or have any open sores? Describe any changes you've noticed in urinating and/or having bowel movements. Mobility. Assessment of patient mobility focuses on Rom, gait, exercise, and activity tolerance, and body alignment. When unsure of a patient's abilities, begin assessment of mobility with the patient in the most supportive position and move to higher levels according to his or her tolerance. Generally, the assessment of movement starts while the patient is lying and proceeds to assessing sitting positions in 414 bed, transfers to chair, and finally walking. This helps to protect the patient's safety. Range of motion. Range of motion, ROM, is the maximum amount of movement available at a joint in one of the three planes of the body, sagittal, transverse, or frontal, figure 28-5. The sagittal plane is a line that passes through the body from front to back, dividing it into a left and right side. The frontal plane passes through the body from side to side and divides it into front and back. The transverse plane is a horizontal line that divides the body into upper and lower portions. Figure 28-5 planes of body. Ligaments, muscles, and the nature of the joint limit joint mobility in each of the planes. However, some joint movements are specific to each plane. In the sagittal plane, movements are flexion and extension, example fingers and elbows, dorsiflexion, and plantar flexion, feet, and extension, example hip. In the frontal plane, movements are abduction and adduction, example arms and legs, and eversion and inversion, feet. In the transverse plane, movements are pronation and supination, hands, and internal and external rotation, hips. Assessment of ROM is important as a baseline measure to determine a patient's mobility status and to later compare and evaluate whether a loss in joint mobility has occurred as a result of clinical changes or treatments. When assessing ROM, ask questions about and physically examine the patient for stiffness, swelling, pain, limited movement, and unequal movement. Chapter 31 describes specific techniques for measuring the degrees of motion in a joint. Patients whose mobility is restricted require Rom exercises to reduce the hazards of immobility. Limited Rom often indicates inflammation such as arthritis, fluid in the joint, altered nerve supply, or contractures. Increased mobility, beyond normal, of a joint sometimes indicates connective tissue disorders, ligament tears, or possible joint fractures. Assess the type of Rom exercise that a patient is able to perform. First, consider the medical plan of care and if active Rom exercises are appropriate, then assess the patient's ability to engage in active Rom exercises. Rom exercises are active, the patient moves all joints through his or her Rom unassisted. Passive, the patient is unable to move independently, and the nurse moves each joint through its Rom, or somewhere in between, table 28-2. For example, you might need to provide support for a weak patient while he or she performs most of the joint movement. Some patients are able to move some joints actively, whereas you will passively move others. Your assessment will help to determine the patient's need for assistance, teaching, or reinforcement. In general, exercises need to be as active as health and mobility allow. Contractures develop in joints that are not moved periodically through their full Rom. Assessment data from patients with limited joint movements vary on the basis of the area affected. Table 28-2. Range of motion exercises. Body part. Type of joint. Type of movement. Range, degrees. Primary muscles. Neck, cervical spine. Pivotal.
Fuck that.
Gait. The term gait describes a particular manner or style of walking. It is a coordinated action that requires the integration of sensory function, muscle strength, proprioception, balance, and a properly functioning CNS, vestibular system and cerebellum. A gait cycle begins with the heel strike of one leg and continues to the heel strike of the other leg. Assessing a patient's gait allows you to draw conclusions about balance, posture, and the ability to walk without assistance, all of which affect the risk for falling. Here are a few ways to assess a patient's gait. 1. Observe the patient entering the room, and note speed, stride, and balance. 2. Ask the patient to walk across the room, turn, and come back. 3. Ask the patient to walk heel to toe in a straight line. This may be difficult for older patients even in the absence of disease, so stay at the patient's side during the walk. Peripheral pulses allows you to evaluate the ability of the heart to pump blood. Immediately document and report the absence of a peripheral pulse in the lower extremities to the patient's healthcare provider, especially if the pulse was present previously. Edema sometimes develops in patients who have had injury or whose heart is unable to handle the increased workload of bed rest. Because edema moves to dependent body regions, assessment of the patient experiencing immobility includes inspection of the sacrum, legs, and feet. If the heart is unable to tolerate the increased workload, peripheral body regions such as the hands, feet, nose, and earlobes are colder than central body regions. To assess for a deep vein thrombosis, DVT, remove the patient's elastic stockings and or sequential compression devices, SCDs, every 8 hours, or according to agency policy, and observe the calves for redness, warmth, and tenderness. Homan's sign, or calf pain on dorsiflexion of the foot, is contraindicated in patients when a DVT is suspected and is no longer considered a reliable indicator in assessing for DVT. Measure bilateral calf circumference and record it daily as an alternative assessment for DVT. To do this, mark a point on each calf 10 centimeters, 3.9 inches, down from the mid-patella. Measure the circumference each day using the mark for placement of the tape measure. Unilateral increases in calf circumference are an early indication of thrombosis. Because DVTs also occur in the thigh, take thigh measurements daily if the patient is prone to thrombosis. A dislodged venous thrombus, called an embolus, can travel through the circulatory system to the lungs and impair circulation and oxygenation, resulting in tachycardia and shortness of breath. Venous emboli that travel to the lungs are sometimes life-threatening. More than 90% of all pulmonary emboli begin in the deep veins of the lower extremities. McCants and Huther, 2014. Musculoskeletal System. Major musculoskeletal abnormalities to identify during nursing assessment include decreased muscle tone and strength, loss of muscle mass, reduced ROM, and contractures. The anthropometric measurements described previously indicate losses in muscle mass. During assessment of ROM, described earlier, you can detect muscle tone by asking the patient to relax and then passively moving each limb at several joints to get a feeling for any resistance or rigidity that may be present. You assess for muscle strength by having the patient assume a stable position and then performing maneuvers to demonstrate strength of the major muscle groups. See Chapter 31. Physical assessment cannot identify disuse osteoporosis. However, patients on prolonged bed rest, postmenopausal women, patients taking steroids, and people with increased serum and urine calcium levels have a greater risk for bone demineralization. Consider the risk of disuse osteoporosis when planning nursing interventions. Although some falls result in injury, others occur because of pathological fractures secondary to osteoporosis. Integumentary system. Continually assess the patient's skin for breakdown and color changes such as pallor or redness. Consistently use a standardized tool such as the Braden scale. The screening tool identifies patients with a high risk for impaired skin integrity or early changes in the condition of patient's skin. Early identification allows for early intervention. Observe the skin often during routine care, example when the patient is turned, during hygiene measures, and when providing for elimination needs. Frequent skin assessment, which can be as often as every hour and is based on patient's mobility, hydration, and physiological status, is essential to promptly identify changes in their skin and underlying tissues. See Chapter 48. Elimination System. To determine the effects of immobility on elimination, assess the patient's total intake and output each shift and every 24 hours. Compare the amounts over time. Determine that the patient is receiving the correct amount and type of fluids orally or parenterally. See Chapter 42. Inadequate intake and output or fluid and electrolyte imbalances increase the risk for renal system impairment, ranging from recurrent infections to kidney failure. Dehydration also increases the risk for skin breakdown, thrombus formation, respiratory infections, and constipation. Immobility impairs gastrointestinal peristalsis. Assessment of bowel elimination status includes the adequacy of a patient's dietary choices, bowel sounds, and the frequency and consistency of bowel movements. See Chapter 47. Accurate assessment enables you to intervene before constipation and fecal impaction occur. Psychosocial assessment. Many alterations in developmental functioning are related to immobility. Often these problems are interrelated, and it is imperative that nursing care focus on all dimensions. Often the focus of immobility is on the easily visible physical problems such as skin impairment, but do not overlook its psychosocial and developmental aspects. Abrupt changes in personality often have a physiological cause such as surgery, a medication reaction, a pulmonary embolus, or an acute infection. For example, the primary symptom of compromised older patients with an acute urinary tract infection or fever is confusion. Identifying confusion is an important component of a nurse's assessment. Acute confusion in older adults is not normal. A thorough nursing assessment is the priority. Ch28 and Ch28, 2012. Common reactions to immobilization include boredom and feelings of isolation, depression, and anger. Observe for changes in a patient's emotional status and listen carefully to family if they report emotional changes. Examples of change that indicate psychosocial concerns are a cooperative patient who becomes less cooperative or an independent patient who asks for more help than is necessary. Investigate reasons for such alterations. Identifying how the patient 420 usually copes with loss is vital. See Chapters 36 and 37. A change in mobility status, whether permanent or not, causes a grief reaction. Families are a key resource for information about behavior changes. Identify and correct unexplained changes in the sleep-wake cycle. Nurses prevent or minimize most stimuli that interrupt the sleep-wake cycle, example nursing activities, a noisy environment, or discomfort. However, some medications such as analgesics, sleeping pills, or cardiovascular drugs also cause sleep disturbances, see Chapter 43. Because psychosocial changes usually occur gradually, observe the patient's behavior on a daily basis. If behavioral changes occur, determine the cause, S, and evaluate the changes. Identifying the cause helps you to design appropriate nursing interventions. Developmental assessment. Include a developmental assessment of patients who are immobilized. When caring for a young child, determine whether he or she is able to meet developmental tasks and is progressing normally. The child's development sometimes regresses or slows because he or she is immobilized. Design nursing interventions that maintain normal development and provide physical and psychosocial stimuli after identifying a child's developmental needs and assure the parents that developmental delays are usually temporary. See Chapter 12. Immobilization of a family member changes family functioning. The family's response to this change often leads to problems, stress, and anxieties. When children see parents who are immobile, they sometimes have difficulty understanding what is occurring and coping. Immobility has a significant effect on the older adult's levels of health, independence, and functional status. Nursing assessment enables the nurse to determine the patient's ability to meet needs independently and adapt developmental changes such as declining physical functioning and altered family and peer relationships. A decline in developmental functioning needs prompt investigation to determine why the change occurred and interventions that can return the patient to an optimal level of functioning as soon as possible. Activities that reduce immobility and promote participation in ADLS are vital to preventing functional decline. Nugruk 2014. QSEN. Ms. Cavell. Nursing diagnosis. A patient who is experiencing an alteration in mobility often has one or more nursing diagnoses. The two diagnoses most directly related to mobility problems are impaired physical mobility and risk for disuse syndrome. The diagnosis of impaired physical mobility applies to the patient who has some limitation but is not completely immobile. The diagnosis of risk for disuse syndrome applies to the patient who is immobile and at risk for multi-system problems because of inactivity. Beyond these diagnoses, the list of potential diagnoses is extensive, because immobility affects multiple body systems. Possible nursing diagnoses include the following: ineffective airway clearance, ineffective coping, impaired physical mobility, impaired urinary elimination, risk for impaired skin integrity, risk for disuse syndrome, social isolation. Assessment reveals clusters of data that indicate whether a patient is at risk or if a problem-focused diagnosis exists. The clusters of data reveal at-risk factors or defining characteristics that are observable assessment cues to support a problem-focused diagnostic label. In the case of a problem-focused diagnosis, the assessment data will reveal a related factor or causative factor for the diagnosis. Identifying the related factor allows you to identify the most appropriate interventions to manage or eliminate the related factor. Accurate identification of nursing diagnoses is important to planning patient-centered goals and subsequent nursing interventions that will best help the patient. Impaired physical mobility related to reluctance to initiate movement requires slightly different interventions than impaired physical mobility related to pain in the left shoulder. Thus it is critical that nursing assessment activities identify and cluster defining characteristics that ultimately support the nursing diagnosis selected, box 28-4. The diagnosis related to reluctance to initiate movement requires interventions aimed at keeping the patient as mobile as possible and encouraging him or her to perform self-care and Rom. The diagnosis related to pain requires the nurse to assist the patient with comfort measures so he or she is then willing and more able to move. In both situations the nurse explains how activity enhances healthy body functioning. Box 28-4. Often the physiological dimension is the major focus of nursing care for patients with impaired mobility. Thus the psychosocial and developmental dimensions are neglected. Yet all dimensions are important to health. During immobilization some patients experience decreased social interaction and stimuli. These patients frequently use the nurse's call bell to request minor physical attention when their real need is greater socialization. Nursing diagnoses for health needs in developmental areas reflect changes from the patient's normal activities. Immobility leads to a developmental crisis if the patient is unable to resolve problems and continue to mature. Immobility also leads to multiple complications, example renal calculi, DVT, pulmonary emboli, or pneumonia. If these conditions develop, 421 collaborate with the healthcare provider or nurse practitioner for prescribed therapy to intervene. Be alert for and prevent these potential complications when possible. Planning. During planning, a nurse synthesizes information from resources such as knowledge of the role of respiratory and physical therapy, standards such as skincare guidelines from the Agency for Healthcare Research and Quality, Ch28, 2013, and the Wound, Ostomy, and Continence Nurses Society, WOCN, 2010, Protocols for Patients at Risk for Falls, AACN, 2014, attitudes such as creativity and perseverance, and past experiences with immobilized patients. Critical thinking ensures that the patient's plan of care integrates all that you know about the individual and key critical thinking elements. Professional standards are especially important to consider when you develop a plan of care. These standards often establish scientifically proven guidelines for selecting effective nursing interventions. Finally, as stated earlier, the patient is a full partner in designing the plan of care, and this input must be reflected when establishing the goals and outcomes. Goals and outcomes. Develop an individualized plan of care for each nursing diagnosis. See the nursing care plan. Set realistic expectations for care and include the patient and family when possible. Set goals that are individualized, realistic, and measurable. The goals focus on preventing problems or risks to impaired body alignment and mobility. Develop goals and expected outcomes to help patients achieve their highest level of mobility and reduce the hazards of immobility. For example, a patient who has left-sided paralysis following a stroke has two long-term goals. The first, directed toward improved mobility, is patient will use walker to ambulate safely in the home. A parallel goal directed toward the hazards of immobility is patient's skin will remain intact. Both of these goals are essential to restoring the patient's maximal mobility. Because the patient has impaired sensation, both the patient and caregivers need to be aware of the patient's need to have the skin free of pressure. Expected outcomes for the goal of the skin remaining intact include the following. Patient's skin color and temperature return to normal baseline within 20 minutes of position change. Patient changes position at least every 2 hours. Setting priorities. The effect that problems have on a patient's mental and physical health determines the immediacy of any problem. Set priorities when planning care to ensure that immediate needs are met first. This is particularly important when patients have multiple diagnoses. Plan therapies according to severity of risks to the patient, and individualize the plan according to the patient's developmental stage, level of health, and lifestyle. It is especially important in priority setting to make sure that you do not overlook potential complications. Many times actual problems such as pressure ulcers and disuse syndrome are addressed only after they develop. Therefore monitor the patient often, reinforcing prevention techniques to both the patient and other caregivers and supervising nursing assistive personnel in carrying out activities aimed at preventing complications of impaired mobility. Teamwork and collaboration. Care of the patient experiencing alterations in mobility requires a team approach. Nurses often delegate select interventions that are appropriate for nursing assistive personnel to perform. For example, in the case of postoperative patients who are at risk for respiratory problems from temporary immobility, nursing assistive personnel, NAP, can encourage the patient to do leg exercises, use the incentive spirometer, and cough and deep breathe. See Chapter 41. When patients have limited mobility as a result of paralysis, NAP can turn and position patients and apply elastic stockings. They can also help the nurse measure leg circumference and height and weight. Collaborate with other healthcare team members such as physical or occupational therapists when it is essential to consider mobility needs. Understanding the need for and having open communications with other members of the interdisciplinary care team results in better patient outcomes and hopefully prevents the hazards of immobility. It is through these collaborative efforts and teamwork that patients benefit most. For example, physical therapists are a resource for planning Rom or strengthening exercises, and occupational therapists are a resource for planning ADLS that patients need to modify or relearn. Wound care specialists and respiratory therapists are often involved in patient care, especially with patients who are experiencing complications related to their immobility. Consult a registered dietitian when a patient is experiencing nutritional problems, and refer him or her to a mental health advanced practice nurse, licensed social worker, or psychologist to assist with coping or other psychosocial issues. Discharge planning begins when a patient enters the healthcare system. In anticipation of the patient's discharge from an institution, make appropriate referrals or consult a case manager or a discharge planner to ensure that the patient's needs are met at home. Consider the patient's home environment when planning therapies to maintain or improve body alignment and mobility. Referrals to home care or outpatient therapy are often needed. Implementation. Health promotion. Health promotion activities include a variety of interventions such as education, prevention, and early detection. Examples of health promotion activities that address mobility and immobility include prevention of work-related injury, fall prevention measures, exercise, and early detection of scoliosis. Prevention of work-related musculoskeletal injuries. The rate of work-related injuries in healthcare settings has increased in recent years. In 2006 there were 4.4 cases per 100 full-time workers who experienced occupational injury and illness compared with 5 cases per 100 for private industry overall. The rate for nursing homes was 10.1 cases per 100 workers, USDL, 2014. Most of these injuries occurred as a result of overexertion, which resulted in back injuries and other musculoskeletal problems. Back injuries are often a direct result of improper lifting and bending. The most common back injury is strain on the lumbar muscle group, which includes the muscles around the lumbar vertebrae. Injury to these areas affects the ability to bend forward, backward, and from side to side and limits the ability to rotate the hips and lower back. Research has demonstrated that ergonomic programs in healthcare facilities reduce costs, injuries to employees, and missed workdays. Hunter et al., 2010. Nurses and other healthcare staff are especially at risk for injury to lumbar muscles when lifting, transferring, or positioning immobilized patients. Therefore, be aware of agency policies and protocols that protect staff and patients from injury. When lifting, assess the weight you will lift and determine the assistance you will need. Current evidence supports that using mechanical or other ergonomic assistive devices is the safest way to reposition and lift patients who are unable to do these activities themselves. Many agencies have developed special patient lift teams and have instituted a no-lift policy. See Chapter 39. Exercise. Although many diseases and physical problems cause or contribute to immobility, it is important to remember that exercise programs enhance feelings of well-being and improve endurance, 423 strength, and health. Exercise reduces the risk of many health problems such as cardiovascular disease, diabetes, and osteoporosis. It is important to give patients options for how to stay active and how to change their behavior if exercise has not been their routine. The Stanford Medicine, 2015, Chronic Disease Self-Management Program encourages appropriate exercise for maintaining and improving strength, flexibility, and endurance. As a nurse, you can encourage all patients to find a type of exercise that meets their lifestyle and particular health-related needs. For example, A patient with severe arthritis of the knees might benefit from aquatic therapy, exercise in a pool, rather than walking. Encourage hospitalized patients to perform stretching, Rom exercises, and light walking within the limits of their condition, see Chapter 39. Collaboration with a physical therapist is recommended. Nurses contribute to promoting health for many patients by encouraging or starting managed exercise programs. Exercise is a key prescription for health promotion of all patients, regardless of their age. In older adults, routine exercise or activity helps maintain Rom and functional mobility and improves balance. Tui and Jet, 2012, Edelman et al., 2013, Elliott, 2011. Take cultural preferences into consideration when helping patients design exercise plans. Box 28-5. Bone health in patients with osteoporosis. Patients at risk for or diagnosed with osteoporosis have special health promotion needs. Encourage patients at risk to be screened for osteoporosis and assess their diets for calcium and vitamin D intake. Patients who have lactose intolerance need dietary teaching about alternative sources of calcium. For patients diagnosed with osteoporosis, early evaluation, consultation with, and referral to healthcare providers, dietitians, and physical therapists are important interventions, especially when they become immobilized. The goal of the patient with osteoporosis is to maintain independence with ADLS. Assistive ambulatory devices, adaptive clothing, and safety bars help the patient maintain independence. Patient teaching needs to focus on limiting the severity of the disease through diet and activity. Box 28-6. Acute care. Patients in acute care settings who experience altered physical mobility usually have some problems associated with the hazards of immobility, such as impaired respiratory status, orthostatic hypotension, and impaired skin integrity. Therefore, design nursing interventions to reduce the impact of immobility on body systems and prepare the patient for the restorative phase of care. Metabolic system. Because the body needs protein to repair injured tissue and rebuild depleted protein stores, give the immobilized patient a high-protein, high-calorie diet. A high-calorie intake provides sufficient fuel to meet metabolic needs and replace subcutaneous tissue. Also ensure that the patient is taking vitamin B and C supplements when necessary. Supplementation with vitamin C is needed for skin integrity and wound healing. Vitamin B complex assists in energy metabolism. If the patient is unable to eat, nutrition must be provided parenterally or enterally. Total parenteral nutrition refers to delivery of 424 nutritional supplements through a central or peripheral intravenous catheter. Enteral feedings include delivery through a nasogastric, gastrostomy, or jejunostomy tube of high-protein, high-calorie solutions with complete requirements of vitamins, minerals, and electrolytes. See Chapter 45. Respiratory system. Patients who are immobilized and have reduced ventilation can benefit from a variety of nursing interventions that promote lung expansion and removal of pulmonary secretions. Patients need to frequently fully expand their lungs to maintain their elastic recoil property. In addition, secretions accumulate in the dependent areas of the lungs. Often patients with restricted mobility experience weakness, and as this progresses the cough reflex gradually becomes inefficient. All of these factors put the patient at risk of developing pneumonia. The stasis of secretions in the lungs is life-threatening for an immobilized patient. Deep breathing exercises, incentive spirometry, controlled coughing, and chest physiotherapy are among the nursing interventions available to expand the lungs, dislodge and mobilize stagnant secretions, and clear the lungs. Chapters 41 and 50. All of these interventions help reduce the risk of pneumonia. It is essential to implement pulmonary interventions early in all patients with limited mobility, even those who do not have pneumonia. Encourage an immobile patient to deep breathe and cough every 1 to 2 hours. Teach alert patients to deep breathe or yawn every hour or to use an incentive spirometer, when ordered. Controlled coughing, a common therapy for postoperative patients, involves taking in 3 deep breaths and then coughing with the third exhalation. Chest physiotherapy, CPT, percussion and postural drainage, is another effective method for preventing pneumonia and keeping the airways clear. See Chapter 41. It helps the patient drain secretions from specific segments of the bronchi and lungs into the trachea so he or she is able to cough and expel them. Respiratory assessment findings identify areas of the lungs requiring CPT. Ensure that patients who are immobile have an adequate fluid intake. Unless there is a medical contraindication, an adult needs to drink at least 1,100 to 1,400 ml of non-caffeinated fluids daily. This helps keep mucociliary clearance normal. Expect pulmonary secretions to be removed easily with coughing and appear thin, watery, and clear. Without adequate hydration, pulmonary secretions become thick and tenacious and difficult to remove. Offering fluids that patients prefer on a regularly timed schedule also helps with bowel and urine elimination and aids in maintaining circulation and skin integrity. Cardiovascular system. The effects of bed rest or immobilization on the cardiovascular system include orthostatic hypotension, increased cardiac workload, and thrombus formation. Design nursing therapies to minimize or prevent these alterations. Reducing orthostatic hypotension. When patients who are on bed rest or have been immobile move to a sitting or standing position, they often experience orthostatic hypotension. They have an increased pulse rate, a decreased pulse pressure, and a drop in blood pressure. If symptoms become severe enough, the patient can faint. McCants and Huether, 2014. To prevent injury, nurses implement interventions that reduce or eliminate the effects of orthostatic hypotension. Mobilize the patient as soon as the physical condition allows, even if this only involves dangling at the bedside or moving to a chair. This activity maintains muscle tone and increases venous return. Isometric exercises, i.e., activities that involve muscle tension without muscle shortening, have no beneficial effect on preventing orthostatic hypotension, but they improve activity tolerance. When getting an immobile patient up for the first time, assess the situation using a safe patient handling algorithm, VISN 8, 2015. This is a precautionary step that protects the nurse and patient from injury and also allows the patient to do as much of the transfer as possible. Reducing cardiac workload. A nursing intervention that reduces cardiac workload involves instructing patients to avoid using a Valsalva maneuver when moving up in bed, defecating, or lifting household objects. During a Valsalva maneuver, a patient holds his or her breath and strains, which increases intrathoracic pressure and in turn decreases venous return and cardiac output. When the strain is released, venous return and cardiac output immediately increase, and systolic blood pressure and pulse pressure rise. These pressure changes produce a reflex bradycardia and possible decrease in blood pressure that can result in sudden cardiac death in patients with heart disease. Teach patients to breathe out while defecating, lifting, or moving side to side or up in bed and to not hold their breath and strain. Preventing thrombus formation. The Centers for Medicare and Medicaid Services identified 10 never events in 2008. A never event is a hospital-acquired event for which Medicare and other third-party payers will no longer pay hospitals at a higher rate for the increased cost of care. Deep vein thrombosis, DVT, is one of these never events. The most cost-effective way to address DVT is through an aggressive program of prophylaxis. Prevention of DVT is critical to reduce the risk of fatal and non-fatal pulmonary embolism. A prophylaxis program begins with identification of patients at risk and continues throughout their immobilization. This requires a collaborative role between nurses and healthcare providers. You will identify patient risk factors from the nursing assessment. There are nursing interventions you can employ to reduce the risk of thrombus formation in immobilized patients. Early ambulation, leg, foot, and ankle exercises, regularly provided fluids, frequent position changes, and patient teaching need to begin when a patient becomes immobile. See Chapter 50. Prophylaxis also includes anticoagulation, mechanical prevention with graduated compression stockings, intermittent pneumatic compression devices, and foot pumps. Anticoagulation may include the use of aspirin, although this is somewhat controversial. Anticoagulants most often used include unfractionated heparin, UFH, usually given as 5,000 units 2 or 3 times daily, low molecular weight heparins, LMWH, example enoxaparin or dalteparin, vitamin K antagonists, example warfarin, but also acinocumarol, phenandian, and dicumarol, and fondaparinux, a selective factor XA inhibitor, Kali, 2007. Because bleeding is a potential side effect of anticoagulant medications, continually assess the patient for signs of bleeding such as hematuria, bruising, coffee ground, like vomitus or gastrointestinal ASP irate, guaiac-positive stools, and bleeding gums. SCDs and intermittent pneumatic compression, IPC, are used to prevent blood clots in the lower extremities. These consist of sleeves or stockings made of fabric or plastic that are wrapped around the leg and secured with Velcro, box 28-7. Once they are applied, connect the sleeves to a pump that alternately inflates and deflates the stocking around the leg. A typical cycle is inflation for 10 to 15 seconds and deflation for 45 to 60 seconds. Inflation pressures average 40 mm Hg. Use of SCD/IPC on the legs decreases venous stasis by increasing venous return through the deep veins of the legs. For optimal results, begin use of SCD/IPC as soon as possible and maintain it until the patient becomes fully ambulatory. Box 28-7. Procedural guidelines. Applying sequential compression devices and elastic stockings. Delegation considerations. The skill of applying elastic stockings and sequential compression devices, SCDs, can be delegated to nursing assistive personnel, NAP. The nurse initially determines the size of elastic stockings and assesses the patient's lower extremities for signs and symptoms of DVT or impaired circulation. Instruct NAP to remove SCD sleeves before allowing patient to get out of bed. Notify nurse if patient complains of pain in leg or if discoloration develops in extremities. When applying elastic stockings, instruct patient to avoid activities that promote venous stasis, example crossing legs, wearing garters. Elevate legs while sitting and before applying stockings to improve venous return. Take precautions and do not massage patient's legs. Avoid wrinkles in elastic stockings. Equipment. Steps. Steps. 1. Identify patient using 2 identifiers, example name and birthday or name and medical record number, according to agency policy.
Why not?
2. Assess for risk factors in Birkhoff's triad. A. Hypercoagulability, example clotting disorders laboratory test results, fever, dehydration. B. Venous wall abnormalities found in patient medical history, i.e., history of orthopedic surgery, atherosclerosis. C. Blood stasis, example immobility, obesity, pregnancy. Clinical decision, clinical signs of thrombophlebitis. Thrombophlebitis vary according to the size and location of the thrombus. Signs and symptoms of superficial thrombosis include palpable veins and surrounding areas that are tender to the touch, reddened, and warm. Temperature elevation and edema may or may not be present. Signs and symptoms of deep vein thrombosis, DVT, include swollen extremity, pain, warm, cyanotic skin, and temperature elevation. Homan's sign, pain in the calf on dorsiflexion of the foot, is no longer considered a reliable indicator. Ball et al., 2015, Greenidge and Werner, 2013. 3. Assess condition of patient's skin and circulation to the legs, example presence of pedal pulses, edema, discoloration of skin, skin temperature, capillary refill, presence of lesions or cuts. Assess for contraindications for use of elastic stockings or SCDs. A. Dermatitis or open skin lesions. B. Recent skin graft. C. Decreased arterial circulation in lower extremities as evidenced by cyanotic, cool extremities. 4. Obtain healthcare provider order. 5. When applying elastic stockings, use tape measure to measure patient's legs to determine proper stocking size. 6. Perform hand hygiene. Also provide hygiene to patient's lower extremities as needed. 7. Assemble and prepare equipment. 8. Explain procedure and reason for applying SCDs or elastic stockings. 9. Position patient in supine position. Elevate head of bed to comfortable level. 10. Option, when applying elastic stockings, apply a small amount of powder or cornstarch to legs provided that patient does not have sensitivity to either. Powder eases application of stockings. 11. Apply SCD sleeve, S. A. Remove SCD sleeves from plastic cover, unfold and flatten. B. Arrange sleeve under patient's leg according to leg position indicated on inner lining of sleeve. C. Place patient's leg on SCD sleeve. Back of ankle should line up with ankle marking on inner lining of sleeve. D. Position back of knee with popliteal opening on the sleeve, see illustration. Step 11. D. Position back of patient's knee with the popliteal opening. E. Wrap SCD sleeve securely around patient's leg. Check fit of SCD sleeve by placing 2 fingers between patient's leg and sleeve, see illustration. Step 11. E. Check fit of SCD sleeve. F. Attach SCD sleeve connector to plug on mechanical unit. Arrows on connector line up with arrows on plug from unit, see illustration. Step 11. F. Align arrows when connecting SCD to mechanical unit. G. Turn mechanical unit on. Green light indicates that unit is functioning. Monitor functioning SCD through one full cycle of inflation and deflation. A typical cycle is inflation for 10 to 15 seconds and deflation for 45 to 60 seconds. Inflation pressures average 40 mm Hg. H. Reposition patient for comfort and perform hand hygiene. I. Remove compression stockings at least once per shift. J. Monitor skin integrity and circulation to patient's lower extremities as ordered or as recommended by SCD manufacturer. 12. Apply elastic stocking. A. Turn elastic stocking inside out by placing one hand into the sock, holding toe of sock with hand. Using other hand, pull sock overhand until reaching the heel, see illustration. Step 12. To turn stocking inside out, hold toe and pull through. B. Place patient's toes into foot of elastic stocking, making sure that stocking is smooth, see illustration. Step 12. B. Place toes into foot of stocking. C. Slide remaining portion of stocking over patient's foot, being sure that toes are covered. Make sure that foot fits into toe and heel position of stocking, see illustration. Step 12. C. Slide remaining portion of stocking over foot. D. Slide stocking up over patient's calf until stocking is completely extended. Be sure that stocking is smooth and that no ridges or wrinkles are present, particularly behind knee, see illustration. Step 12. D. Slide stocking up leg until completely extended. E. Instruct patient not to roll stockings partially down because constricting ring around leg can occlude circulation. F. Instruct patient not to massage legs. G. Reposition patient for comfort and perform hand hygiene. H. Remove stockings at least once per shift. I. Inspect stockings for wrinkles or constriction. J. Inspect elastic stockings to determine that there are no wrinkles, rolls, or binding. Elastic stockings, sometimes called anti-embolic stockings, also aid in maintaining external pressure on the muscles of the lower extremities and thus promote venous return, see box 28 to 7. To obtain the correct size, measure the patient's calf, thigh, and leg length accurately. When considering applying graded compression stockings, first assess the patient's suitability for wearing them. Do not apply them if he or she has a local condition affecting the leg, example any skin lesion, gangrenous condition, or recent vein ligation, because application 427 compromises circulation. Apply them properly and remove them at least once per shift. Be sure to assess circulation at the toes to ensure that the stockings are not too tight. Another device for preventing DVT is the venous plexus foot pump. It promotes circulation by mimicking the natural action of walking. Proper positioning reduces a patient's risk of thrombus formation because compression of the leg veins is minimized. Therefore, when positioning patients, use caution to prevent pressure on the posterior knee and deep veins in the lower extremities. Teach patients to avoid the following: crossing the legs, sitting for prolonged periods of time, wearing clothing that constricts the legs or waist, and massaging the legs. Report suspected DVT immediately to the patient's healthcare provider. Elevate the leg but avoid pressure on the suspected thrombus area. Instruct the family, patient, and all healthcare personnel not to massage the area because of the danger of dislodging the thrombus. Rom exercises reduce the risk of contractures and aid in preventing thrombi. Activity causes contraction of the skeletal muscles, which in turn exerts pressure on the veins to promote venous return, thereby reducing venous stasis. Specific exercises that help prevent thrombophlebitis are ankle pumps, foot circles, and knee flexion. Ankle pumps, sometimes called calf pumps, include alternating plantar flexion and dorsiflexion. Foot circles require the patient to rotate the ankle. Encourage patients to make the letters of the alphabet with their feet every 1 to 2 hours. Knee flexion involves alternately extending and flexing the knee. These exercises are sometimes referred to as anti-embolic exercises and need to be done hourly while awake. Musculoskeletal System. Exercises to prevent excessive muscle atrophy and joint contractures help maintain musculoskeletal function. If a patient is unable to move part or all of the body, perform passive Rom exercises for all immobilized joints while bathing the patient and at least 2 or 3 more times a day. If one extremity is paralyzed, teach the patient to put each joint independently through its Rom. Patients on bed rest need to have active Rom exercises incorporated into their daily schedules. Teach patients to also integrate exercises during ADLS. Some orthopedic conditions require more frequent passive Rom exercises to restore the function of the injured joint after surgery. Patients with such conditions may use automatic equipment, continuous passive motion CPM, for passive Rom exercises, figure 28-9. The CPM machine moves an extremity to a prescribed angle for a prescribed period. Researchers continuously investigate uses for CPM. Patients who had a rotator cuff repair and received CPM therapy to their affected shoulder reported a decrease in pain in one study and improved muscle strength in another, Duplessis et al., 2011. However, in a recent systematic review, CPM was shown to not have clinically important effects on active knee flexion, ROM, pain, function, or quality of life to justify its routine use for patients who undergo a total knee arthroplasty, Harvey, et al., 2014. Figure 28-9 Continuous passive range of motion machine. Integumentary system. The major risk to the skin from restricted mobility is the formation of pressure ulcers. Early identification of high-risk patients helps prevent pressure ulcers, see Chapter 48. Interventions aimed at prevention include turning and positioning and the use of therapeutic support surfaces to relieve pressure. Regular skincare, cleansing of soiled areas and use of moisturizers, aims to maintain the condition of the skin. Change the immobilized patient's position according to his or her activity level, perceptual ability, treatment protocols, and daily routines. For example, an obese patient or a very thin patient, both of whom have bowel incontinence, will require more frequent turning than standard practice. Although turning every 1 to 2 hours is standard practice for preventing ulcers, it is sometimes necessary to use support surface devices, example air loss mattresses, heel boots, flotation mattresses, for relieving pressure. Usually the time that a patient sits uninterrupted in a chair is limited to 1 hour. This interval is shortened in patients who are at very high risk for skin breakdown. Reposition patients frequently because uninterrupted pressure causes skin breakdown. Teach patients to shift their weight in a chair every 15 minutes. Chair-bound patients need to have a device for the chair that reduces pressure, Ch28 al., 2013. Elimination System. The nursing interventions for maintaining optimal urinary functioning are directed at keeping the patient well hydrated and preventing urinary stasis, calculi, and infections without causing bladder distension. Adequate hydration, example at least 1,100 to 1,400 ml of non-caffeinated fluids daily, helps prevent renal calculi and urinary tract infections. The well-hydrated patient needs to avoid large amounts of dilute urine that is approximately equal to fluid intake. Also record the frequency and consistency of bowel movements. Provide a diet rich in fluids, fruits, vegetables, and fiber to facilitate normal peristalsis. If a patient is unable to maintain regular bowel patterns, stool softeners, cathartics, or enemas are sometimes necessary. If the patient is incontinent, modify the care plan to include toileting aids and a hygiene schedule so the increased urinary output does not cause skin breakdown. Psychosocial changes. Use assessment data to identify the psychosocial effects of prolonged immobilization. People who have a tendency toward depression or mood swings are at greater risk for developing psychosocial effects during bed rest or immobilization. 428 Anticipate changes in the patient's psychosocial status and provide routine and informal socialization. Observe the patient's ability to cope with restricted mobility. In institutional healthcare settings, do not schedule nursing care activities between 10 p.m. and 7 a.m. to minimize sleep interruptions. For example, administer medications and assess vital signs when you enter the room to turn the patient or provide special skincare. If the nursing care plan is not improving coping patterns, consult a clinical nurse specialist, counselor, social worker, spiritual advisor, or other healthcare professional. Incorporate their recommendations into the care plan. Nurses provide meaningful stimuli to maintain a patient's orientation. Plan nursing activities so a patient is able to talk and interact with staff. If possible, place him or her in a room with others who are mobile and interactive. If a private room is required, ask staff members to visit throughout the shift to provide meaningful interaction. A daily newspaper helps the patient keep track of events and time. Bedside conversations at appropriate moments familiarize him or her with nursing activities, meals, and visiting hours. Books help occupy the patient when he or she is alone. The patient can participate in craft activities. iPods, MP3 players, radio, television, and videotapes provide stimulation and help pass the time. Involve patients in their care whenever possible. For example, encourage the patient to determine when the bed should be made. Some patients rest better during the night when fresh sheets are put on in the evening rather than in the morning. The patient needs to provide as much self-care as possible. Keep hygiene and grooming articles within easy reach. Encourage patients to wear their glasses or artificial teeth and shave or apply makeup. People use these activities to maintain their body image, thus improving their outlook. Developmental changes. Ideally, immobilized patients continue normal development. Nursing interventions can help. Nursing care needs to provide mental and physical stimulation, particularly for a young child. Incorporate play activities into the care plan. For example, completing puzzles helps a child to develop fine motor skills, and reading helps him or her develop cognitively. Encourage parents to stay with a child who is hospitalized. Place a child who is immobilized with children of the same age who are not immobilized unless a contagious disease is present. Allow the child to participate in nursing interventions such as dressing changes, cast care, and care of traction. The nurse needs to recognize significant changes from normal behavioral patterns and consult with a pediatric clinical nurse specialist, counselor, or other healthcare professional. Restricted mobility of older patients presents unique nursing problems. Older patients who are frail or have chronic illnesses are often at increased risk for the psychosocial hazards of immobility. Maintaining a calendar and clock with a large dial, conversing about current events and family members, and encouraging visits from significant others reduce the risk of social isolation. Spending time in the room talking and listening to the patient also helps reduce the risk of social isolation. Nurses need to encourage older immobilized patients to perform as many ADLs as independently as possible. Patients need to continue to perform personal grooming if they did so before their mobility was restricted. This type of activity preserves the patient's dignity and gives him or her a sense of accomplishment. Positioning techniques. Patients with impaired nervous, skeletal, or muscular system functioning and increased weakness and fatigue often require help from nurses for positioning and maintenance of proper body alignment while in bed or sitting. See Skill 28-1 on pages 432 to 438. Several positioning devices are available for maintaining good body alignment for patients. Pillows are positioning aids and are sometimes readily available. Before using a pillow, determine whether it is the proper size. A thick pillow under a patient's head increases cervical flexion, which is not desirable. A thin pillow under bony prominences does not protect skin and tissue from damage caused by pressure. When additional pillows are unavailable or if they are an improper size, use folded sheets, blankets, or towels as positioning aids. Apply positioning boots to prevent foot drop by maintaining the feet in dorsiflexion. Ankle foot orthotic, AFO, devices also help maintain dorsiflexion. Patients who wear positioning boots or AFOs need to have these removed periodically, example 2 hours on, 2 hours off. A trochanter roll prevents external rotation of the hips when a patient is in a supine position. To form a trochanter roll, fold a cotton bath blanket lengthwise to a width that extends from the greater trochanter of the femur to the lower border of the popliteal space, figure 28-10. Place the blanket under the buttocks and roll it counterclockwise until the thigh is in neutral position or inward rotation. When the hip is aligned correctly, the patella faces directly upward. Use sandbags in place of or in addition to trochanter rolls. Sandbags are sand-filled plastic tubes or bags that are shaped to body contours. Hand rolls maintain the thumb in slight adduction and in opposition to the fingers, which maintain a functional position. Evaluate the hand roll to make sure that the hand is indeed in a functional position. Hand rolls are most often used with patients whose arms are paralyzed or who are unconscious. Do not use rolled washcloths as hand rolls because they do not keep the thumb well abducted, especially in patients who have a spastic paralysis. Hand wrist splints are individually molded for a patient to maintain proper alignment of the thumb, slight adduction, and wrist, slight dorsiflexion. Use splints only on the patient for whom they were made and follow the splint schedule, example wear for 2 hours, remove for 2 hours. Figure 28-10 trochanter roll. The trapeze bar is a triangular device that hangs down from a securely fastened overhead bar that is attached to the bed frame. It allows a patient to pull with the upper extremities to raise the trunk off the bed, assist in transfer from bed to wheelchair, or perform upper arm exercises, figure 28-11. It increases independence, maintains upper body strength, and decreases the shearing action from sliding across or up and down in bed. Figure 28-11 patient using trapeze bar. Although each procedure for positioning has specific guidelines, there are universal steps to follow for patients who require positioning assistance. Following the guidelines reduces the risk of injury to the musculoskeletal system when a patient is sitting or lying. When joints 429 are unsupported, their alignment is impaired. Likewise, if joints are not positioned in a slightly flexed position, their mobility is decreased. During positioning also assess for pressure points. When actual or potential pressure areas exist, nursing interventions involve removal of the pressure, thus decreasing the risk for development of pressure ulcers and further trauma to the musculoskeletal system. In these patients use the 30-degree lateral position. Supported Fowler's position. In the supported Fowler's position, the head of the bed is elevated 45 to 60 degrees, and the patient's knees are slightly elevated without pressure to restrict circulation in the lower legs. The patient's illness and overall condition influence the angle of head and knee elevation and the length of time that the patient needs to remain in the supported Fowler's position. Supports need to permit flexion of the hips and knees and proper alignment of the normal curves in the cervical, thoracic, and lumbar vertebrae. The following are common trouble areas for a patient in the supported Fowler's position. Increased cervical flexion because the pillow at the head is too thick and the head thrusts forward. Extension of the knees, allowing the patient to slide to the foot of the bed. Pressure on the posterior aspect of the knees, decreasing circulation to the feet. External rotation of the hips. Arms hanging unsupported at the patient's sides. Unsupported feet or pressure on the heels. Unprotected pressure points at the sacrum and heels. Increased shearing force on the back and heels when the head of the bed is raised greater than 60 degrees. Supine position. Patients in the supine position rest on their backs. In the supine position, the relationship of body parts is essentially the same as in good standing alignment, except that the body is in the horizontal plane. Use pillows, trochanter rolls, and hand rolls or arm splints to increase comfort and reduce injury to the skin or musculoskeletal system. The mattress needs to be firm enough to support the cervical, thoracic, and lumbar vertebrae. Shoulders are supported, and the elbows are slightly flexed to control shoulder rotation. A foot support prevents foot drop and maintains proper alignment. The following are some common trouble areas for patients in the supine position. Pillow at the head that is too thick, increasing cervical flexion. Head flat on the mattress. Shoulders unsupported and internally rotated. Elbows extended. Thumb not in opposition to the fingers. Hips externally rotated. Unsupported feet. Unprotected pressure points at the occipital region of the head, vertebrae, coccyx, elbows, and heels. Prone position. The patient in the prone position lies face or chest down. Often his or her head is turned to the side, but, if a pillow is under the head, it needs to be thin enough to prevent cervical flexion or extension and maintain alignment of the lumbar spine. Placing a pillow under the lower leg permits dorsiflexion of the ankles and some knee flexion, which promote relaxation. If a pillow is unavailable, the ankles need to be in dorsiflexion over the end of the mattress. Although the prone position is seldom used in practice, consider this as an alternative, especially in patients who normally sleep in this position. The prone position also may have some benefits in patients with acute respiratory distress syndrome and acute lung injury, Barbas et al., 2012. Specialty beds that safely position acutely ill patients in the prone position are available. Assess for and correct any of the following potential trouble points with patients in the prone position. Neck hyperextension. Hyperextension of the lumbar spine. Plantar flexion of the ankles. Unprotected pressure points at the chin, elbows, female breasts, hips, knees, and toes. Side-lying position. In the side-lying, or lateral, position, the patient rests on the side with the major portion of body weight on the dependent hip and shoulder. A 30-degree lateral position is recommended for patients at risk for pressure ulcers, see Chapter 48, Ch28 al., 2013. Trunk alignment needs to be the same as in standing. The patient needs to maintain the structural curves of the spine, the head needs to be supported in line with the midline of the trunk, and rotation of the spine needs to be avoided. The following trouble points are common in the side-lying position. Lateral flexion of the neck. Spinal curves out of normal alignment. Shoulder and hip joints internally rotated, adducted, or unsupported. Lack of foot support. Lack of protection for pressure points at the ear, shoulder, anterior iliac spine, trochanter, and ankles. Excessive lateral flexion of the spine if the patient has large hips and a pillow is not placed superior to the hips at the waist. Sims position. Sims position differs from the side-lying position in the distribution of the patient's weight. In Sims position, the patient places the weight on the anterior ilium, humerus, and clavicle. Trouble points common in Sims position include the following. Lateral flexion of the neck. Internal rotation, adduction, or lack of support to the shoulders and hips. Lack of foot support. Lack of protection for pressure points at the ilium, humerus, clavicle, knees, and ankles. 430. Moving patients. When moving a patient during repositioning, a safe transfer is the first priority. Patients require various levels of assistance to move up in bed, move to the side-lying position, or sit up at the side of the bed. For example, a young, healthy woman may need support as she sits at the side of the bed for the first time after childbirth, whereas an older man may need help from 2 or more nurses to do the same task 1 to 2 days after surgery. Always ask patients to help to their fullest extent possible. To determine what a patient is able to do alone and how many people are needed to help move him or her in bed, assess him or her to determine whether the illness contradicts exertion, example cardiovascular disease. Next, determine whether the patient comprehends what is expected. For example, a patient recently medicated for postoperative pain is too lethargic to understand instructions, thus to ensure safety 2 nurses are necessary to move him or her. Then determine his or her comfort level. It is important to evaluate your personal strength and knowledge of the procedure. Finally, determine whether the patient is too heavy or immobile for you to move alone. VISN 8, 2015, see Chapter 39. Restorative and continuing care. The goal of restorative care for the patient who is immobile is to maximize functional mobility and independence and reduce residual functional deficits such as impaired gait and decreased endurance. The focus in restorative care is not only on ADLs that relate to physical self-care but also on instrumental activities of daily living, IADLs. IADLs are activities that are necessary to be independent in society beyond eating, grooming, transferring, and toileting and include such skills as shopping, preparing meals, banking, and taking medications. Nurses use many of the same interventions as described in the health promotion and acute care sections, but the emphasis is on working collaboratively with patients and their significant others and with other healthcare professionals to facilitate the patient's return to maximal functional ability in both ADLs and IADLs. Intensive specialized therapy such as occupational or physical therapy is common. If the patient is in a rehabilitation institution, he or she likely goes to the therapy department 2 to 3 times a day. The nurse's role is to work collaboratively with these professionals and reinforce exercises and teaching. For example, after a stroke, a patient likely receives gait training from a physical therapist, speech rehabilitation from a speech therapist, and help from an occupational therapist for ADLs such as dressing, bathing, and toileting, or household chores. The therapy is not always able to restore total functional health, but it often helps the patient adapt to the mobility limitations or complications. Equipment frequently used to help patients adapt to mobility limitations includes walkers, canes, wheelchairs, and assistive devices such as toilet seat extenders, reaching sticks, special silverware, and clothing with Velcro closures. Range of motion exercises. To ensure adequate joint mobility, teach the patient about Rom exercises. Walking also increases joint mobility. Patients with restricted mobility are unable to perform some or all Rom exercises independently. Provide Rom exercises to maintain maximum joint mobility. To ensure that patients routinely receive Rom exercises, schedule them at specific times, perhaps with another nursing activity such as during the patient's bath. This enables the nurse to systematically reassess mobility while improving the patient's Rom. In addition, bathing usually requires that extremities and joints are put through complete Rom. Passive Rom exercises begin as soon as a patient's ability to move an extremity or joint is lost. Carry out movement slowly and smoothly, just to the point of resistance. Rom should not cause pain. Never force a joint beyond its capacity. Each movement needs to be repeated 5 times during a session. When performing passive Rom exercises, stand at the side of the bed closest to the joint being exercised. Use a head-to-toe sequence and move from larger to smaller joints. If an extremity is to be moved or lifted, place a cupped hand under the joint to support it. Support the joint by holding the adjacent distal and proximal areas, figure 28 to 12, or support the joint with one hand and cradle the distal portion of the extremity with the remaining arm, figure 28 to 13. See table 28 to 2 for detailed ROM for each joint. Appropriate ROM exercises are based on the patient and the affected joint. Figure 28 to 12 supporting joint by holding distal and proximal areas adjacent to joint. Figure 28 to 13 cradling distal portion of extremity. Walking. When a patient has a limited ability to walk, assess his or her activity tolerance, tolerance to the upright position, orthostatic hypotension, strength, the presence of pain, coordination, and balance to determine the amount of assistance needed. Explain how far the 431 patient should try to walk, who is going to help, when the walk will take place, and why walking is important. Some settings have distances marked along hallways to measure a patient's progress. Other facilities use accelerometers to measure distance walked. In addition, determine with the patient how much independence he or she can assume. Check the environment to be sure that there are no obstacles in the patient's path. Clear chairs, overbed tables, and wheelchairs out of the way so the patient has ample room to walk safely. Before starting, establish rest points in case activity tolerance is less than estimated or the patient becomes dizzy. For example, place a chair in the hall for the patient to rest if needed. A nurse who does not have a lot of strength and who is unable to ambulate a patient alone needs to request help and ensure that the patient has an assistive device such as a walker, see Chapter 39. A nurse stands on either side of the patient, and each holds one side of the gait belt. Provide support at the waist by using a gait belt so the patient's center of gravity remains midline. While walking, the patient should not lean to one side because this alters the center of gravity, distorts balance, and increases the risk of falling. Return a patient who at any point appears unsteady or complains of dizziness to a nearby bed or chair. If the patient faints or begins to fall, assume a wide base of support with one foot in front of the other, thus supporting the body weight, figure 28 to 14, A, B, C. Then gently lower the patient to the floor, protecting the head. Although lowering a patient to the floor is not difficult, the nursing student needs to practice this technique with a friend or classmate before attempting it in a clinical setting. Figure 28 to 14A, stand with feet apart to provide broad base of support. B, extend one leg and let patient slide against it to the floor. C, bend knees to lower body as patient slides to floor. Patients with hemiplegia, one-sided paralysis, or hemiparesis, one-sided weakness, often need assistance with walking. When an assistive device is used, stand on the patient's affected side and support him or her with a gait belt. Providing support by holding the patient's arm is incorrect because the nurse cannot easily support the patient's weight to lower him or her to the floor if he or she faints or falls. In addition, if the patient falls with the nurse holding an arm, a shoulder joint may be dislocated. Evaluation. Through the patient's eyes. Just as it was important to include the patient during the assessment and planning phase of the care plan, it is essential to have the patient's evaluation of the plan of care. Were the goals met, or is more work required? You must now determine with the patient and others involved with care if the goals or outcomes established with and for the patient have indeed been met, what still needs to be achieved from the patient's perspective, and whether it is necessary to revise a new plan of care. In other words, how have the patient's expectations changed and in what ways? Patient outcomes. From your perspective as the nurse, you are to evaluate expected outcomes and a patient's response to nursing care and compare the patient's actual outcomes with the outcomes selected during planning, such as his or her ability to maintain or improve body alignment, joint mobility, walking, moving, or transferring. Evaluate the effectiveness of specific interventions designed to promote body alignment, improve mobility, and protect the patient from the hazards of immobility. Evaluate the patient's and family's understanding of all teaching provided as well. The continuous nature of evaluation allows you to determine whether new or revised therapies are required and if new nursing diagnoses have developed. When outcomes are not met, consider asking the